We'll discuss together the clinical implication of long-acting antivirals. These are my disclosures. And I started just as to sum it up, what we know about the use of long-acting agents in other fields of medicine. We know that, for example, with antipsychotics, they improve patients' adherence. They're usually poor, and actually, as a hard endpoint, we reduce the number of hospitalizations. We have also data on long-acting bisphosphonates and on long-acting contraceptives, and recently on long-acting anti-migraine agents. And globally, all these long-acting agents improve patient adherence and reduce discontinuation rates. That is something could be really relevant in our population and in some hard-to-treat population. Well, what do I have in common as a, let's say, treatment outcome? It's they do increase patient preference. In all this field, patients prefer to reduce less doses and to come to the clinic as less time as possible. So what we have, let's say, in the pipeline. So we already have one drug that has been approved, ibalizumab, for patients with drug-resistant viruses. We do have albuterol, but just registered in China, that is an enhanced version of enfuterol. We'll soon have long-acting cabotegravir and rilpivirine, and we have a very interesting pipeline. I will not spend time on these drugs. At the end, just give you a few hints of what I think could be a very interesting combination of these drugs together. So I just put a few slides. I just let them in a slide. So if you want to go back and check, like the mechanism, half-life, route of administration, could be useful to have them on a safe slide, but we'll not get into details. Just would like to point out that it would be somehow hard to combine drugs with different route of administration. So if you have one intravenous, one is subcutaneous, another one is intramuscular. I think combining them together is a bit of a challenge for patients to remember. And also the route of the time of administration is relevant. You can't give a drug once a month, the second one every 2 or 3 months. I think it would be very confusing. So having somehow a symmetry among the drugs would be really relevant for improving patients' adherence. So I actually planned this presentation and dividing it into what will not change and what will change in clinical practice, from my personal opinion. And what will never change, I wanted to bring politics, is Italy politics. I just want to point out in blue that Italy had 65 governments in 73 years. It's probably a record. And so that will never change. So what will not change? Efficacy. So what we know. I tried to plot all the studies we have on long-acting cabotegravir and rilpivirine. The last one, just bear in mind, is just a press release, so we don't have actual data. But the press release in August suggested that in the Atlas 2, the once a month was non-inferior to every 2 months administration of these drugs. As you can see, the treatment efficacy is really good. Even on long term, in the latitude, even the numbers were low, you see that there are a sustained response up to 160 weeks. So we now have data suggesting that medium to long term efficacy is pretty good. And I also wanted to point out how many patients in all these studies discontinued long-acting cabotegravir rilpivirine for virological failure. And actually the number are again very low. So it's 12 patients over 900 enrolled individuals. So it's a 1.3% rate of discontinuation for virological failure. Again, bear in mind that it's trial, so we will have probably the best patients enrolled, the first patient on this trial, so probably real life is slightly different, and that's something we don't know now, but the numbers are really encouraging. And why do they stop, actually, in the studies? This is the Atlas. I tried to take one of those just to give you an idea, and as you can see, patients discontinued due to adverse events or death. It's the second row. It's 3.6% in the long-acting arm, compared to 1.6 in the oral arm medication. But if you go and take a look at the real reason for discontinuing, you see that 4 out of these 11 were acute hepatitis. So it's nothing to do with the drugs. And you might have actually only 4 patients that discontinued for real side effects: headache, depression, memory impairment, diarrhea, nausea, and headache, even if you might have different causes. If you compare it to oral, I don't think there's a real signal here as for tolerability. What about selection of RAMs? That will be really important. If you lose future option, that will be really relevant for choosing these drugs or not. What we know, we do have two data, let's say. The first one is Latitude, has already been published. And we see that in this study, you see numbers were small, but we only had 2 patients that selected resistant mutation, both in the NRTI and in the integrase gene. However, if you just take a look at the B point, one loss of biological control was observed at week 4, and the measured repeat concentration were 0. And the measured repeat concentration at week 8, they were 0 again. That's absolutely not what we see usually when we see the administration of these drugs. So probably it was not administered or maladministered, suggesting that at least one of these is not relevant to clinical practice, or might be relevant in case we have problems with administering those drugs. This table put together the data presented at IAS, so it's a combined analysis of the Atlas and the FLAIR study, and you see they had 6 patients with a resistance-associated mutation. As you can see, the first 2 already had mutations for rilpivirine at a baseline, and they didn't select anything. So I think it's really somehow reassuring that even if one of the 2 drugs wasn't working at all, you don't select resistance in integrase. That's something somehow reassuring. So we actually have 4 patients that had no mutation at baseline, these 4 here, and had mutation in both genes, phosphatase and integrase, at failure. What they have in common? They have in common that actually they were, the study were, these participants were in Russia, but all of them were genotype A. So IAS, there was a lot of discussion if probably substitution, we can discuss it afterward, Jonathan, if the certain substitution in the integrase gene can favor the selection of further mutation. They also did a sub-analysis suggesting that if the prevalence or the absence of L74I was associated with failure in the whole patient, that it was not. So actually, we don't know at the moment. Still, 4 patients selected mutation in both genes. That is something that somehow worries them in this setting. So again, what will not change? Tolerability. What do we know? All the side effects seem to be pretty similar to the injectable and oral medication, with pyrexia, headache, and fatigue, the most common. Actually, we don't know if they're related. Something relevant is injection site reaction, and I wanted to point it out here. As you see, injection site reactions are usually mild. They tend to decrease over time. Patients suggest they accept them, and only 1% of patients discontinued because of injection site reaction. So they're there. We need to inform patients that they might have some swallowing, some pain, but tell them that usually after the first injection, the relevance of this injection reaction decreases, and they may feel better. So weight gain, Laura did a great presentation before. I wanted to point out that we have so far just one data. It's for HPTNN 077, so only using long-acting cabotegravir. And in this study, there were no weight gain at all. And so we still have to see what happens in patients. They were healthy volunteers. We need to see what's going on. But it could be the cabotegravir is slightly different, and I will show you some data on PK to dolutegravir and bictegravir, at least in some of the potential drug-drug interactions. So tissue exposure, something really relevant for us in a setting of eradication, functional cure, etc. So what we know about genital exposure? This is rilpivirine data in the vaginal fluid and cervicovaginal mucosa. This is a rectal mucosa. And you see that most of the patients have very high levels in the mucosa. You still have some patients that are very low, mostly in the female genital tract. But now we know that the let's say, rate of protection from infection is very good in a setting of PrEP. So I think it should be reassuring. And also, we know for cabotegravir that the amount of drug that get to cervical and vaginal is pretty cool. It's similar to oral drugs. Well, we still have to see what's going on in the rectal tissue. But again, PrEP studies suggest it could be effective. So we still need to work a little bit about tissue concentration in these settings, but I think data so far are reassuring. What about CSF? We just have one data presented by Scott Tender last year. And you see that in blue here that the rate, how much drug gets into the CSF is very low, 0.3% for cabotegravir and 1% for rilpivirine. But the amount of drug that's in the CSF seems to be pretty cool for suppressing the drug there. And I think more interestingly, all patients were suppressed both in plasma and CSF, below 50 copies. You might see here some certain numbers. You see that if you use a super low assay, 2 copies per ml, there were some patients actually not being below 2 copies in the CSF, but when you look at the real numbers, how much were the CSF HIV RNA copies were 3, 5, 5, and 15 and 42 copies. So we don't get a signal that this treatment can increase the replication of HIV in the CNS, CSF. So what will change? Well, I think there are some things that should change, and I hope the new government in Italy at least address this. It's really relevant. I think treatment satisfaction will change. What we know now that in the latest study, patients were really, really happy of being in the study. They're really happy to keep on. They prefer every 2 months administration, but even when we do every month, they were pretty cool as compared to oral drugs. And also in the Flaring Atlas, you see the treatment satisfaction scores. There's a global measure of satisfaction were good. If you go again to the details, at IAS they presented all the sub-analysis of this satisfaction, and you see the patients were really cool, like be continuing with intramuscular medication. They found it flexible, they found it the convenience of this treatment, much easier than oral medication, so globally they thought it was better for them. So I think treatment satisfaction will increase in our patients. What about adherence? Well, adherence is 100%. If you take the drug, if you go through your appointment, 100% of adherence, then that's pretty easy. However, one concern for our pharmacologists is how long is the tail of a drug. So if you stop it, so you don't show to the clinic for your shot, for how long you will have the drug just going around a very low concentration. That is the worst situation, the best situation for selecting mutations. So that's something worrisome to some extent. If you take a look, the long-acting cabotegravir tail is really, really long. These are healthy volunteers, and you see that for up to 48 weeks, you still see very low concentration of long-acting cabotegravir. So if you miss a dose for a long time, that will be somehow worrisome. And if you do in the HPTN 077, you see that some patients were at high risk of having super long concentration. And they were female and patients with high BMI. And I think that has to do with the amount of muscle to fat in which the drug needs to be reabsorbed. It's called a flip-flop pharmacokinesis. There's a change between the depot and the circulation. So probably if you have more fat, you might have a delayed release of the drug. So those categories were those that had the highest chance of having drugs at 76 weeks. So over 1.5 years, you still have a concentration going on. Could this be bad? Well, actually, in one of the PrEP studies with long-acting rilpivirine, low-dose long-acting rilpivirine, there's a patient that actually was exposed to HIV here. She got HIV with a very long tail of rilpivirine going on. Again, this is 240 days, so almost 1 year. And you see here she got HIV and she got a K101E mutation, suggesting that this long tail can favor the selection of this mutation. Then she started hard, she was suppressed enough in, let's say, serious in the point of selection, but it may theoretically be a problem patients just not presented for their shots. Well, service organization, that need to change. We need to plan to prepare for it, because we need to stop patients, so we need to prepare for that. We need to get large fridges. At the moment, long-acting rilpivirine need to stay in the fridge. There are big boxes, so every patient should have a box that is this dimension, so you need a large fridge. How many patients are going to treat? You might need large fridges. And you also need to, let's say, organize how and when patients come and what to do if they don't come. We'll call them on the phone, what to do. That's one of the things that could be open for discussion. What about PK? I just like it for if you want to look at it. It's really unreadable, just to get a look. Just take in mind that rilpivirine has a low potential to cause DDIs, but average potential to be a victim of DDIs, while cabotegravir is pretty cool. I just skip it. But bear in mind also that there's a difference when you administer drugs orally and when you get them intramuscular subcutaneously. It is that you skip first pass metabolism, because drugs don't have to go from the gut to the liver and then systemic circulation. So you reduce somehow the amount of interaction you get at the liver side. And so just to give you an example, what will happen with cabotegravir and rifampicin? So we do have models, made a nice study by Marco Siccardi group in Liverpool. And you see if you give oral cabotegravir with rifampicin, you get a 60% reduction in AUC. So probably you can't give rifampicin with oral cabotegravir. But what will happen if you give long-acting cabotegravir with rifampicin? Well, the model tells us that it's just a 25% reduction. We might still want to compensate for it. So for example, we might think of giving an extra oral drug oral dose of cabotegravir during the rifampicin administration, but we need to actually test it with models before doing it. But you see, the amount of interaction is much smaller because we just skip the liver in the first pass. There's not much of cabotegravir as a victim. We know that estrogen drugs, so hormonal contraceptives, are not affecting cabotegravir. We know that cabotegravir might affect OET1 and OET3, these two transporters, and however, the amount of this interaction is believed to be low. So if you check with other substrates, such as methotrexate, ciprofloxacin, cidofovir, etc., the amount of interaction seems to be below 25%. So at the moment, not clinically relevant. I just want to point out in red that cabotegravir is not an OCT2 inhibitor. So we won't see the creatinine increase as per Dole and Beek. We won't see interaction with metformin. And in my personal opinion, that OCT2 has to do with neuropsychiatric side effects. So I think we will see much less neuropsychiatric side effects, and maybe weight gain depends on OCT2. We actually do in genotype on OCT2 to understand if there's a genotypic reason for weight gain, but we'll see in the future. What will change in the future? New technologies. What about implants? Implants have a lot of advantages. They're removable, they can stay there for 1 to 5 years. PK is not dependent on the site, because you can inject in different sites, there's slightly difference. If you give an implant, usually it's in the arm, nothing happened, there's no difference. However, you need a specialized tool to get in there. If there are side effects, you need a minor surgical operation to take it out, and regulation is more complex. So it's both a material and a drug, so it needs more time, and that's why moving to a generic marketplace will be really hard. However, we already have data actually in experimental animal and tough implants, but also IAS that showed the first results of MK-8591, so the FDA, the new Translocate Inhibitor by Merck. And this is the implant, it's 4 centimeters by 2 millimeters. It's super small. It's going to be tested in PrEP at the moment, but it's going to be really relevant for treatment as well if you find companion drugs for this interesting technology. And as you can see, they show the first results in the first patients, healthy volunteers, sorry, and they model how much drug will be released over a year, and you see that triphosphorylated concentration will be very, very high here in this curve for more than 1 year. So we still don't know for how long it may stay there, but probably 1 to 3 years. Excellent from PrEP, very interesting for treatment once we know what to do, what to give with it. And again, future is micropatches. You can actually prepare these very small cones and cover it with drug. And just to give you an idea, this chart Flexner Arm, and you see how a micropatch is. So you put it in there, you keep it there for a certain amount of time, then you remove it. So the problem is, how large should be this thing for releasing a sufficient amount of drug? Actually, the modeling so far for cabotegravir, this is the first model again for Marco Siccardi, is like something like 20 centimeters by 20 centimeters. So it's still too large. You can just go up with this over your body. But still, it's something really interesting, and it could be the future. So it's painless and seems pretty stable among different patients. New drugs. What do we have? Well, I think the one that is more advanced is MK-8591. That's now called islatravir. Funny thing. We do have data suggesting that it's a nucleoside reverse translocate inhibitor, so it works in a different way on RT. You see, it works at very low concentration, and the data we have now, even orally, it can give even once a week. So it seems to be a pretty nice drug for long-acting. Very high genetic barrier to resistance, could be really nice. We need to see how to combine it with other drugs. That is something we still need to figure. There are broad-spectrum monoclonal antibodies. There are a lot of on study. I just want to point out this one at Croix, but it was really interesting for the fact that a few patients, after a single infusion, get control of HIV without the need of other infusion. So we're just 2 patients out of 9, but still, those patients just didn't require any other treatment for 6 months. So, long half-life, interesting mechanism of action, we'll see. And just to mention that in May, a study by the ACTG started trying to see if long-acting cabotegravir plus one of these broad-spectrum border-neutralizing antibodies could work together as a maintenance therapy. So we're already starting to combine drugs together. We have an interesting monoclonal antibody anti-CCR5. It's called Pro-140. At Croix, they show, again, a maintenance treatment. So suppressed patients with R5 virus, they stop all the drugs and just receive a once-a-week subcutaneous administration of this drug. Actually, interestingly, there were some failure at the very low dose administration. But if you look at the highest dose of this drug, very well tolerated, you get that 86% of patients maintain a suppression for 6 months with every week subcutaneous injection. Interesting. We need, again, to see how to combine it in just for R5 tropical viruses. And finally, at Croix, we had the first data, and IIS also the first data on GS6207. It's a capsid inhibitor that a very, very long half-life, and so could be, again, combined every 3 to 6 months probably. We'll see. We need more data on that. So which are the open issues? Adherence. Now patients usually come to the clinic 2-3 times a year. They will have to come every month at this moment. So some patients may actually don't want to. What to do in case patients missing their shots? I think that's something important. What about patients that are traveling a lot? Should give them some oral drug for reserve, so to take with them in case they miss a few days. We need to, again, to answer the question. There were 6, but actually only 4 real selection of RAMs in the Atlas of FAIR studies. There were genotype A. We may discuss a little bit more about resistance. What about extreme phenotypes? Patients with very low BMI and very high BMI. There were some signal on PK, on low BMI. We still need to see what's going on. And again, DDI, we need to, drug-drug interaction, we need to think what to do. Maybe switch oral drugs could be an option, but we can give higher or lower doses in case of things. So in conclusion, I want to remind you that the EU won the Nobel Peace Prize in 2012. So I think EU, this is one of the things that should not change at all. So long-acting antivirals will be probably game-changing interaction in the armamentarium and probably increase patients' preference and quality of life, I think. A few issues still need to be assessed in clinical practice, such as this BMI, adherence, maybe resistance. I think also something, what to do in patients who have failed to adherence. They just have K13N. Could it be given or not? I think something we need to think about, as well as the organization of outpatient services. And again, should we just select with patient to just and call them, say, oh, now we have long-acting. You want the long-acting, or just suggest there's long-acting, and who wants just pop up and we'll try to. So I think organization of to which patient suggest it or propose it is something, again, we should work. And again, new drugs and technology will probably even increase the efficacy and tolerability of these regimens and may give us a very nice future in treatment of HIV. Thank you for your attention.